Hi, I'm Ryan Curran, and this is my Kinesiology 353 critical assignment, and I'm doing the sport of soccer. And so, to get started, I'll be discussing some factors that might cause injury for soccer. So, the first thing I'll be listing is skill level, and skill level is important to take into consideration when taking into consideration injuries because there can be a drastic change in the severity of injuries depending on if somebody is playing at a child's level, for example, AYSO soccer, when you're 5, 6, 7, 8 years old, compared to someone who's playing at a collegiate level. And that goes because um, multiple different things. When you're younger, your skill level is not quite as good. You might not know how to land properly. You might not know how to avoid a slide tackle properly, which would result in younger people potentially getting injured more frequently. But when it comes to severity of injuries, most likely the severity of injuries will be higher as the level gets higher. For example, at a collegiate level, someone is going to be running down the field much quicker, and the movements are going to be much more aggressive than somebody who is in the 5, 6, 7 year age range, young AYSO, middle school, high school, whatever that might be. The game starts to speed up as you get older and more competitive, and therefore the injuries can be more severe because the movements are more drastic. So it can actually go both ways. Age level is also very important to take into consideration. If you're someone who's an older person and you're playing in a recreational league, it doesn't matter necessarily the speed of the game. If you're someone who's much older and you have an injury, your body's going to react to it differently. You're going to most likely be worn out quicker. The injury will be a little bit easier to activate. The injury will be harder to heal from. So that's something to take into consideration. Usually, the younger the person, if they're in their athletic prime or a little bit younger, the healing process is a bit faster, and the injuries generally are less severe. And then gender is important too, because as we've learned in the past, there's certain injuries that certain genders are more prone to occurring and are prone to experiencing. For example, ACL tears are, I believe, 3 times more, or around 3 times more likely to happen to a female athlete than a male athlete, and that's because of the physical anatomy of the female and the way their body reacts with kicking and running and movements like that. So that's also very important, gender. So I'm going to move on to inversion ankle sprain anatomy. And as you can see, I have listed here what a normal ankle looks like, grade 1, grade 2, grade 3. And to briefly go over it, the ligaments that are affected are the ATFL, the anterior talofibular ligaments, the PTFL, the posterior talofibular ligaments, and the CFL, calcaneofibular ligaments. And so we have 3 grades, much like many other injuries. Grade 1 is stretching with minor tear. It's generally around 5 to 10% of the muscle is torn, no more than that. Grade 2 would be moderate tearing of the ligaments, so you start to see it would show up much more in an MRI, and they wouldn't be so microscopic. Grade 3 would be a complete tear of the ligament, so it would be the ligament. If it was the CFL, it would be completely torn all the way through. Grade 3 generally the most painful and has the highest recovery process. So moving on, the mechanism of injury in an inverted ankle sprain. I listed the most common type of ankle sprain is an inverted sprain. That's when the foot moves medially in towards the body. It's much more common because that's the way that the joint is more apt to turn when your foot is landing wrong or landing on somebody else's foot. External rotation on the foot is much less common. Inverted ankle sprain is caused by the ankle becoming inverted and the foot having too much plantar flexion. So also when your toe gets stuck down and inverts at the same time, generally the worse that is, the more severe the sprain is. You can also have just some internal rotation without plantar flexion, but those sprains tend to be a little bit less severe. So MOI 1, mechanism of injury 1, listed was landing incorrectly on the outside of the foot while attempting lateral movement when switching direction towards the ball. So if a soccer player is trying to make a quick movement because the ball gets passed by maybe a player that they're defending, or they're trying to make an adjustment to reach a ball, it's pretty common for, you can actually see in the picture here, the player, it looks like he wasn't even being contacted maybe, and he tried to make a move from the left to the right or quickly to the left, and that ended up in his foot plantar flexing slightly and his foot internally rotating in the grass as he was trying to turn the other way, and that's also not good because he's putting his motion going to the right, and the grunt of it is going to the left, internally rotating the foot even further. The mechanism of injury number 2 is landing on an opponent's foot after returning to the ground after jumping for a header. So this happens a lot in basketball too. When you go out for a rebound, you come down and land on someone's foot. I've personally broken my ankle doing that, and had many grade 2 tears playing basketball, landing on somebody else's foot. It's the same thing with soccer. There is a lot of jumping in soccer, which I think most people don't realize, and a lot of landing on other people's foot, and that obviously would result in somebody else's foot being here, your foot sliding off, plantar flexing, and internally rotating. So now we move on to inversion ankle sprain assessment and treatment, and the 2 assessments that I have listed here be the talar tilt test and the anterior drawer test. So the talar tilt test, you want the person to either be laying down or sitting down. The ankle needs to be at 90 degrees, so the foot will be upwards like this. And a positive talar tilt test occurs when the calcaneofibular ligament is sprained. So pretty much what you would want to do is you can have the foot and you can internally rotate it and externally rotate, and you can even have both feet here, match it, and if one extends further than the other, aka tilting more than the other, then that's a concern or a sign that the ligament has been stretched or torn. And the anterior drawer test, you would lay the person down completely flat. Their ankle once again would be at 90 degrees like this. You would place one hand on the heel, one hand on the lower leg, and you would put pressure upwards on the heel while holding down the bottom of the leg. And generally the ankle is going to slide forward a little bit, but if it slides forward too much, or it's making a clicking noise, or if it slides forward and doesn't have a sudden strong stop, that is also an indication that there is a sprained ankle, potentially grade 2 or potentially grade 3. And then the treatment for sprained ankles I put was RICE, which is just rest, ice, compression, elevation, classic. I'm kind of basing that off of a grade 2 or maybe even a grade 1 sprain. Grade 3 sprain might need something more drastic, but RICE is generally a go-to for ankle sprains. So now let's discuss inversion ankle sprain preventative exercises. I started with a back squat, basic back squat, doing 5 sets, 5 repetitions 2 times a week. We're only doing it 2 times a week because it's a pretty heavy exercise. It's preventative, it's not rehabilitation. So we do 5 sets, 5 repetitions, pretty heavy weight. We want to be getting the muscles around the ankle stronger. And then we progress into a sumo squat. It's a variation of a squat with the legs spread out further, generally using a kettlebell, and that would just help work out different muscles that are used in the squat that also help stabilize when making quick movements, and but it is different than a traditional back squat. And next we move on to weighted calf raises. So these are good. You can do them on a machine, you can do them with holding dumbbells, even do them with a barbell technically. I once again listed 5 sets, 5 reps, 2 times per week. You don't want to get the repetitions too high because you want it to be, you want to be able to be doing a high percentage of what you're capable of in terms of weight. In progression, I would go into a one-footed calf raise, and you can do that weighted too. You can either do it on a machine, but you need to be careful with that one because one-footed calf raises start to bring a lot of balance into it. And then inversion ankle rehab exercises, we do the ABC toe tracing, which I've listed before, which is, as we know, putting your toe in a motion and keeping your leg completely extended and your knee completely extended, and then your ankle is tracing the alphabet. 4 sets, 60 seconds, 10 times per week. It's a pretty easy exercise, but when you're rehabbing, it's something that's important to keep the blood flowing, the muscles moving, doesn't stay stagnant. You progress into a supported calf raise, so 2 feet on the ground, calf raise, probably holding onto a chair. And then we do towel scrunches, where you actually put your knee up like this, flexed, foot should be on the floor, flat here, and under your foot, you would put a towel, and you're actually scrunching with your toes together, squeezing the towel together, and you're using your toes here, and this is using all the muscles and the ligaments that connect your lower leg into your foot. So that's a really good one to do. I would do 2 sets of 15 repetitions, 10 times per week. And I did 15 reps, a little bit higher than what I would normally put because the motion is so small and so short that it's easy to get through that quickly. And then I would progress into a one-leg balance where you're holding yourself up on the leg that's injured, and you're balancing for 20 to 30 seconds. You can be using support too with one hand if you need. So now we're going to be moving on to hamstring strain. The affected muscles are the semitendinosus, the semimembranosus, biceps femoris, the long head and the short head both. And much like an ankle sprain, there are 3 grades to this. There's grade 1, grade 2, grade 3. Grade 1 is stretching, maybe microscopic tearing. Grade 2, you start to get, partial tearing, and then it's a moderate strain. And then grade 3 would be a severe strain, and it would be a complete tearing of a muscle, which would be incredibly painful in the hamstring because of how thick the biceps femoris and the semitendinosus and all the muscles there are. So moving on to the mechanism of injury for hamstring strains. It is generally caused by knee extension, so your knee would be straight or somewhat straight with extensive hip flexion, so the hip would be up, away from the body, forward. Mechanism of injury 1 is extending the lead running leg while sprinting down the field. So a lot of times in soccer there'll be a play on the ball where the ball goes over your head, or you have to make a play on a defensive player, and you have a sudden sprint, and a sudden sprinting motion can definitely be a mechanism of injury that can extend the knee and extend the hip too quickly and cause a tear in the muscles on the hamstring. The MOI2, while making a leaping motion over a opposing player who's attempting to slide tackle you, the lead leg leaps over, extends with too much hip extension. So a lot of times in soccer, you'll be dribbling the ball down the field, and someone will come in for a slide tackle, and either you're trying to avoid injury or you're trying to get around him to continue the play. And what happens a lot of times is it's a leaping motion rather than a jumping motion. So one foot is extended in front of you, and a lot of times that extension of the knee and the hip together can cause a strain of the hamstring. So now moving on to assessment and treatment for the hamstring strains. I listed passive range of motion tests, so we'd probably lay somebody down flat like we can see in this picture. This picture is not a great representation because it looks like the athlete is forcing her foot forward, but in reality we'd be doing it passive, so we would actually be having support from somebody else holding their leg, and you would be moving it yourself. And then active range of motion test would be similar, where the knee is flexing, you're flexing the knee, and then you're actively doing it yourself, so you're working on the muscle and without assistance. And that can give you a good idea of what place you're at in the severity of the hamstring strain, maybe before you get an MRI, or how you're progressing after you've been doing rehab. Treatment, I put police treatment here, which is protection, optimum loading, icing, compression, elevation. So protection is pretty straightforward. For the first few days of the injury, you want to rest the injured joint, and then you want to move on to optimal loading, and this is when you start to do gentle motions, for example, a lot of passive range motions, and then you move on from that, and you move on to ice, applying ice, much like Rice would require, and applying ice to it to keep the blood flow down, keep the swelling down, helps healing quicker, helps keep the pain down, and then you want to keep compression on it for C, which would be maybe using something like an ACE bandage, some kind of wrap, keep it together, supported, and swelling down that way. And then elevation is good because of the decrease of blood flow to that part of the body. And let's move on from there. So hamstring strain preventative exercises. We did weighted lunges, 5 sets, 5 reps, 2 times per week, and we progressed into weighted step-ups. So they're similar to lunges, except we're using a little bit more range of motion with our legs. And then we did leg curls, 5 sets, 5 reps, 2 times per week again, and then we progressed into a deadlift. Hamstring strain rehabilitation exercises. We start with a prone laying flat on the ground hamstring curl. This is kind of an awkward workout once I actually implemented it, but it definitely works the right muscles. And we would do 3 sets of 8 repetitions, 10 times per week. This would be unweighted. This is a hard exercise to actually put weight on. You can do it, but you have to grip the feet together and hold the weight like a dumbbell with the feet as you're doing it, and it's a little awkward can be kind of dangerous, especially for somebody who's rehabbing. And then we would do a non-weighted bridge. That's when you sit on your back and your pelvis goes